Yeah, my name is Peter. I'm a paediatric intensivist in Glasgow, which is a mixed cardiac ICU and general ICU. So I've been asked to talk a little bit about paediatric cardiac patients, focusing on babies particularly. So from my point of view, these patients can be pretty scary, but they're the fun patients in my opinion. I love cardiac ICU. That's where I work, where I do. And for a lot of people, this is how you might feel or react when you hear that there is a cardiac baby coming into resus or to the emergency department, or who's become unstable on the wards. Sometimes you know they're a cardiac patient, sometimes you don't, and that's always quite challenging. And I would say that, even though I work in a cardiac centre with cardiologists and physiologists, cardiac surgeons, ECMO teams, it can still be pretty nerve-wracking. And if you don't have that backup, you don't have those capabilities, it can be even more stressful and difficult. So hopefully we'll go through a little bit of information that may or may not prove useful. It is impossible to cover congenital heart disease, emergency physiology in 30 minutes, let alone sort of 30 hours, to be honest. But we'll touch through some key concepts. So if I were to say to you that you get a standby call, there's a baby coming into resus, and let's just say that they are, 1 week, 2 weeks, 3 weeks, 4 weeks old, somewhere in and around that remit, and they're presenting as a neonatal collapse, and they are apneic, and their airway is currently being maintained, and they're being bag mask ventilated. You know that they're acidemic. Their pH is 6.8. Their CO2 is 6, so they're being effectively bag mask ventilated, really. But their lactate is markedly elevated at 8, and their blood sugar is low at 2. Now, I know this is a cardiac talk, which is going to make this really super biased. But I just thought the first question I'd want to put to you guys is, what do you think the likely diagnosis is? I'll give you, say, 30 seconds to think about that.
Sepsis is coming up as the most likely thing, with cardiac defect second, metabolic third, abuse fourth, and something else as fifth.
Awesome. Okay, so I deliberately gave you those options because in my head, scams is the things that I think about whenever a child presents as a neonatal collapse. And it is important to have a framework in your mind as to what this might be. Now, you guys are absolutely right. By far and away, sepsis is the most common of all of these presentations. But it doesn't mean that it's not something else, right? So you have to have some sort of way of thinking through the differentials. A patient who is septic, yeah, they might present apneic, they might present cold, mottled, shut down, with apneas if they're in the neonatal phase of their life, with low blood sugar. That is absolutely how they might present, but it could equally be a cardiac lesion of numerous different etiologies. Unfortunately, yes, non-accidental injuries can present like this as well, as can metabolic disorders, inborn errors of metabolism, or something else. Every now and again, you get some sort of weird bowel condition, or there might be a congenital defect that has not been picked up at birth. And we've seen diaphragmatic hernias being picked up relatively late sometimes. So you have to keep a broad open mind as to what might be going on. Either way, the approach to management is, in my opinion, ABC 5P. Now, most talks will go through an ABC approach to management, so I'm not going to go through that in huge amounts of detail. For me, there are a few considerations if you've got a cardiac patient, but as I say, you may not know that it's a cardiac patient in your resus. And 5P refers to a way to approach management of neonatal collapse, and it does exist in some nationally available guidelines. So it's worth thinking about how you would step through that. There's no doubt in this case the baby's apneic already, so the airway has to be your first port of call in terms of actions, and we'll get to that in a second. But before I tell you what my 5Ps are, I'm just going to put the question out there about, does anyone have any thoughts about what 5Ps may or may not stand for? You might know, you might not know, and that's absolutely fine. But I just want you to have a think about things that it might be. I'm happy to learn from you guys. It might be that by the end of this talk, we've got 10 Ps, and that's absolutely fine. But I'm just going to put that out there. Okay, so I can see some of those answers coming through. So we've got Prostin. People know this is a cardiac talk, so awesome. Pulses, penicillin, pallor, panic is there, yep, perfusion, pre-postductal sats. So all of these things are absolutely, important. Prepare is a good one. People impressors, pulses, pupils, yeah, okay, awesome. I'm going to come to these in a wee second. But the first thing I would say, and it's just a stock image to show an absolute natural disaster, which in this circumstance, in this picture, is already happening. But for me, when you've got a cardiac baby in your resus who's already apneic, or any cardiac patient, they might be in your ICU or they might be on the wards. If you're setting up to intubate a patient who is this unwell, you have to expect that it's all going to go badly wrong. Not out of being totally negative, but just being realistic that this patient's physiology is pretty extreme sometimes. And a neonate's the same position. They may not be a cardiac neonate, but they still are fairly precarious. So I challenge everybody in these circumstances to think about how they might want to act and how they might want to plan for the impending disaster that you presume is going to happen. You hope that it doesn't, but it might. In my unit, we have got patients not infrequently with cardiomyopathy, and it may be that we have to intubate these patients. And in our unit, we will do that with a full ECMO team standing, scrubbed, prepared behind us, that if it all goes wrong, we have got the option of cannulating this patient in an emergency scenario onto ECMO. So even in a experienced cardiac center, we have a full preparation procedure to step through, recognizing that not everybody's going to have those capabilities. So I've showed this on a slide, not because I expect you to read through it all, but this is a version of our intubation checklist that we use for our cardiac patients, but we actually use it for all of our patients. And there is a few key things just that I will point out on this checklist. If you don't have a checklist like this, I would encourage you all to create one. There's plenty available online in terms of having a look through the options and creating something that you think is useful and relevant to your place of work. If you already are working in a cardiac unit, it might be that this child, or even not a cardiac unit actually, you might recognize that this child has been intubated before. If you've got electronic records, it's not too slow a process to find out what the previous grade of intubation was, particularly if it's recent. Yes, in some scenarios, you can optimize their condition in terms of making sure they're fasted, etc. But in an emergency scenario, you just have to get on with it. And that's one of the key messages here. If you've got an apneic patient who's acidemic and they might have congenital heart disease, it's okay to panic, but you do need to act, and that's really crucial. Now, there's always chat about passing NG tubes and aspirating them and trying to optimize conditions. If you've got a baby who is flat and not doing much, then that's largely okay. If you've got a cardiac patient who is not flat, who's actually agitated, who's got a heart rate of 220, who's on the very edge of their physiology, the last thing I want to do is then tip them over the edge by upsetting them and shoving something up their nose. So I'll absolutely be prepared to insert an NG tube. I'll have it measured and I'll have it lubricated, but I wouldn't do it until they're lightly sedated. From an oxygenation point of view, you inevitably will hear people worrying about how much oxygen and what saturation should a cardiac patient have. And I get that. I absolutely understand that. There are some cardiac lesions that you require a balanced circulation. And to put that into simple terms, what that means is that they have blood. If you think about it, they have blood in a common ventricle, for example, and that blood can either go to their pulmonary circulation or their systemic circulation. It gets to choose. And you have to manipulate their physiology to direct a proportion of that to the lungs and a proportion of that around the body. And if you are in that scenario, largely we would be aiming for saturations between 75 and 85%. But in many scenarios, like a resus scenario, you don't actually know that. So the important thing is to get on and support the left ventricle. And the best way to do that is to secure an airway and improve, their hemodynamics that way. Positioning stuff I'm not going to go through. And I don't think I need to go through equipment with you because that's an entirely separate talk. For me, the team section on this slide is absolutely crucial. You need to think about who your team leader is and who your first and second intubators are, just should the procedure be difficult. Where I work, if I'm the team leader, the next person, whoever's the most experienced at intubation should be your intubator. Now, if they struggle, we might change roles depending on who we have available. And you need to have an airway assistant. You need to have somebody on drugs. You need to have somebody recording times. You may or may not need somebody to be free to activate ECMO callouts. From a CPR point of view, I will always have 2 people allocated to do chest compressions. They will always be asked to stand at a set side of the bed, in my opinion. And they will be asked to alternate chest compressions every 2 minutes religiously. Every time they hear a 2-minute call, they must swap. And if I feel either of them are getting tired, or the chest compressions are ineffective, I will swap them out early. And as a leader, you have to be able to stand back and acknowledge that, but be absolutely prepared for that to happen. I have had that happen before, and we've been very grateful that we've been as prepared as that. So always anticipate that things will go wrong. From a medications point of view, I'm not going to go through all of these medications, obviously. Use medications that you A, are happy with, but B, are the right choice for your patient, recognizing that if this is a cardiac patient, their cardiac output is inevitably going to be reduced. Therefore, the drugs will take a lot longer to work than you might expect, and you should be really slow and cautious to minimize the detrimental effects of these agents. So for me, in my unit, we would regularly use fentanyl, ketamine, and rocuronium to put people off to sleep. And the doses that we would normally use are 2 mics per kilo of fentanyl, 2 milligrams per kilogram of ketamine, and 1 per kilo of rocuronium. So for a cardiac patient, I might just use a 0.5 to 1 mic per kilo of fentanyl and wait a good 3 minutes for that to take effect. And if I can, I will be really slow in putting these patients off to sleep, keeping a really close eye on their hemodynamics. Yes, Chris talked really nicely earlier about adrenaline and push dose adrenaline and adrenaline infusions. That, for me, in my opinion, that will depend partly on where you are and what access you have available. And I certainly wouldn't wait trying to put in central lines or trying to put in, if the IOs are failing, then I will go to push dose adrenaline rather than worry about adrenaline infusions at that point in time. Because sometimes you just need to get on and act, but people will have their own opinion on that, and that's okay. The 5 Ps that we talked about earlier, they are triggers to make you think about that differential diagnosis and how you might think about it. And I agree with all of the ones already mentioned that aren't on this slide in terms of people and preparation. Those are crucial Ps too. Penicillin is about thinking about what antibiotic you might want to give this patient to cover sepsis. For the vast majority, they might use a cephalosporin, and that's fine. Prostin, a non-negotiable if this child might have duct-dependent congenital heart disease. You need to start them on Prostin. Phenylbutyrate is useful if you think they've got an inborn error of metabolism, and it is important to send an ammonia off on these collapsed neonates. If that's elevated, they need to go to a centre that will be able to provide hemofiltration, preferably a centre that can provide hemofiltration plus have a metabolic team available. From a protection point of view, if you think that there's a chance of a non-accidental injury, this child needs to be kept in a safe environment, and you do need to think about what other children might be at home and make sure that they are safe too. POCUS refers to point of care ultrasound. Again, I mentioned previously undiagnosed diaphragmatic hernias. So this can be really useful to try and ascertain what the diagnosis might be when you're still not sure. And the 6th one that I would add is PICU. It's really important that you look for sources of advice and support in these scenarios. And the reason I showed the intubation checklist that we had is that I think it's really important to be aware where you can find sources of information, guidelines, help, support, and your PICU and your local retrieval team is crucial to that process. So for this patient, hopefully you'll be able to see my mouse on the screen. You may not, but this patient, if you follow the blood flow in the heart, because congenital heart disease is all about the plumbing, right? It's all about plumbing, volume, flow, and pressure. And you can argue whether flow or pressure is more important. That will be debated till the end of time. But for this patient, blood going into the right ventricle will come out into the pulmonary trunk. It then has options. It can go right or left into the branch pulmonary arteries, or in this case, it can go across the patent duct and down the aorta. So that duct is crucial to supply blood flow into the descending aorta. That, in this circumstance, is the role of the duct. If you see the blood that would be coming into the left ventricle, it goes out the aorta, but it only goes so far because there's an interruption in that aortic arch. So for this patient, if this duct was to close, there is now no longer any way for blood to get down the descending aorta. So therefore, they will become acidemic and they will become mottled and become increasingly unwell and present similar to how this case presented. So there are other left-sided obstructive lesions that might present very similar to this, such as critical aortic stenosis or a coarctation. So it's about thinking what it might be. The other trap not to fall into is that in this circumstance that I'm describing, the duct is essential for systemic circulation. You can be in a scenario where the duct is crucial for pulmonary circulation. Okay, so it's not always as straightforward as some people might think. Again, the crux of this talk is where can you find sources of support? Obviously, I'm not going through this entire slide, but South Thames Retrieval Service, Shauna mentioned them earlier, and I used to work there, and they have fantastic resources in terms of their guidelines that are freely available online. And what I love about them is that they're really quite concise. So their neonatal collapse guideline is, I think, maybe 2, maybe stretched to 3 pages now, but it's super easy to follow, and if you follow this from the top, and it guides you in terms of initial resuscitation, early intubation and ventilation, IV access, giving fluids, giving antibiotics. Very quickly, it prompts you to consider a duct-dependent cardiac lesion, and it moves you over to the grey boxes on the right side of this page. So it immediately starts the thought process, because what you don't want to do is miss something that you could effectively treat, right? Now, I recognise that this is a little bit blurry because it's just zoomed in from the previous page, but there are sometimes clues that this might be a duct-dependent lesion, such as cyanosis not responding to oxygen. So you might be able to give as much oxygen as you can into the lungs, but if you don't have blood flow into the pulmonary arteries, you're not going to be on a winner. If the problem's getting blood to the systemic circulation, you might have difficult to feel or absent femoral pulses. You might notice differences in falling blood pressures, saturations. There may or may not be heart murmurs, an enlarged heart. Bottom line for me is there's a really low threshold to start prosting. I know that some district general hospitals, this makes them nervous, and I understand that. And they'll sometimes start it at 5, and then, they'll say, oh, should we increase it to 10? Should we? What do you think? Get it in. This patient in this presentation is already apneic. There is no point, and I hear this all the time, I'm worried about putting them on high-dose prostin in case they become apneic. They're already apneic. Get it in and treat the patient. And you can't delay these things. So I would be straight in with 20, and I have a very low threshold to crank it on up to 50 to 100. You do need to recognise that there are consequences to every medication that you use, but you also have to recognise that if you don't treat the patient adequately, the complication of that is much more significant. Don't delay the transfer, so that's why you have to have early engagement with your transport team and your intensive care, and have a low threshold for intubation. If the SATs are low, if they're apneic, if they're acidemic, or if they're on high-dose prostin, most of us would make sure the kid was intubated so they don't have ongoing or recurring issues with apneas in the back of an ambulance. Now, I don't think necessarily for most of the specific diagnoses you need to get into your head about that and stress too much. There are some signs that might direct you towards the specific lesion, and they do exist within the same guideline. The one in blue I would mention, an obstructed total anomalous pulmonary venous drainage, is a terrible one to get because there is nothing that you can do that will make this patient better. Okay, what the definitive action that is needed for a child with obstructed TAPVD is surgery, and you can't do that where you are if you're in a district general hospital. And it's another reason for early involvement with your cardiology or your cardiac ICU to recognise that this might be the diagnosis. And you need to get this patient to a definitive centre as early as possible. It's not unusual for these patients to be brought in a transport trolley with saturations of 20, 30 and terribly high lactates, and we'll stick a probe on them whilst they're still in the transport trolley, say, yes, it's TAPVD, go straight to theatre. They don't even stop in ICU. They just need to get to where they need to get to, and that can be pretty scary. To briefly mention another case, sometimes people say, oh, it's not too bad because the mum and dad have given you this letter, and so therefore you know the diagnosis. Now, if it's 3 in the morning, you're not a cardiologist or a cardiac intensivist, and somebody says this patient's got double outlet right ventricle, transposition of the great arteries, a ventricular septal defect, and pulmonary stenosis, you might think, oh my God, what on earth is that? And that's quite reasonable, to be quite honest. So that is really challenging, right? This is what that looks like. And the parents tell you, oh, he's had a previous shunt inserted and he's been unwell for, a week and a half, diarrhea and vomiting. It was sort of settled, then it got worse again. And the heart rate's 190 and SATs are only 50, and you can't hear any murmurs. Now, if I go through this diagram of the heart, the blood's going into the right atrium, goes into the right ventricle, but they've got a big VSD, right? So to keep things really simple, because I'm a very simple-minded person, functionally there's this one big single ventricle type scenario here because of the size of the VSD. And the blood can go out either the aorta or it can go out into the pulmonary arteries. Yes, they're malpositioned, but it can go out either of them, except this patient's got pulmonary stenosis. And if it's a severe pulmonary stenosis, that will mean that they do not get adequate blood flow going to their lungs. So there has to be another way to facilitate that blood flow. Therefore, this patient has had a BT shunt. And if you remember a BT shunt, most circumstances that will come off the right brachiocephalic artery into the right pulmonary artery. And like all shunts, it will have a very loud, obvious, long, continuous murmur. So if this child is not saturating and you can't hear a murmur, that suggests there's no blood flow going down that shunt. So it's blocked, or it's shunt, or it's kinked, or it's twisted. Something is wrong with that. So again, I'll say to you, what are you going to do about that? Where can you find sources of help and support? Another reason to sim this type of scenario. This would be a more rare scenario, because that usually, if there's problems with a BTT shunt, that usually happens in the first sort of 24, 48 hours post-operatively. So I'd be more likely to see this in my cardiac ICU than I think you would be. But I think you do need to be aware of the concept. This diagram on the left-hand side shows where the shunt exists. And you can imagine if that's blocked, that there is no longer adequate blood flow getting into the PAs. Again, I'm sharing a Glasgow guideline with you because I think it is quite useful, and you can find this freely available. Search a Google search, go to section 3 here if you think they've got a blocked BT shunt. In this scenario, what you want to do is to try and make it easy for the blood to get to the lungs, right? Now, it might be that this BTT shunt is only partially occluded or partially twisted, and there is some blood flow that can get down it into the pulmonary arteries. So how do you encourage that? First thing, obviously, is call for help. If you are able to, call in the relevant people. This child needs definitive surgical intervention on their shunt. You work through your resuscitation ABC as before, but you have to initiate treatment and not delay things. So simple things are ventilate the patient, make sure that you're giving them oxygen as required, make sure that you do what you can to reduce their pulmonary vascular resistance. You want to encourage blood to flow into their pulmonary arteries. So keep them sedated, keep them muscle relaxed. Other things that will help that is keeping their CO2 normal to low, make sure their oxygen levels are high, and give them a bolus of magnesium. Now, if you can, it's useful to also try and drive blood flow down the partially occluded shunt into the pulmonary arteries, and you can do that by using pressors. And I know Chris has already talked about pressors. There are some examples here of pressors that you might want to consider using, plus an adrenaline infusion. Most units will have their own limited experience of which they like to use, and you have to work through that as a team. Fundamentally, try and anticoagulate this patient, try and unblock the shunt. So we would recommend giving a bolus of heparin, which can be repeated as a half dose after 15 minutes, and start a heparin infusion. If the patient's still really young, you might find that they have the remnants of a ductus arteriosus, and if you start prostatin, that might give you another avenue to augment your pulmonary blood flow. So it's another consideration to have. But you really, fundamentally, for this patient, need to have your team involved, team activated, ready to go, ready to do what needs to be done. So I just wondered if people would mind sharing from the two cases that we briefly touched on what your take-home points might be from this before I share mine. Okay, so there's things coming through like being prepared, Proston, structured approach, 5 Ps, work in a cardiac centre. Everyone is welcome to come and work in a cardiac centre. They're phenomenal, but I'm very biased. Checklists and momentum. Yeah, I agree with all of those things, to be honest. For me, it's consider the cardiac diagnosis in the first place and don't forget about it. Prepare for instability, and people talk about that in terms of the teamwork and preparation. I think that is really crucial because this can all go badly wrong. Discuss these patients early and use resources. I think genuinely, if you're not in a cardiac centre, you do need to think about simulation and running through these variations of these scenarios as a team as to how you would do it. Where would you access support? What guidelines might be available to you in your region? And who would you call and how do you get hold of them out of hours? And what's the quickest way and what's the correct phone numbers to use? There have been circumstances where I've seen people try to phone the wrong number quite a number of times, and that delays things quite significantly. And then to consider definitive care and location for these patients. And I'll finish there.